Hi, welcome everyone. This is session 5, Elevating Health Equity for Every Person, and I'm delighted to welcome Dr. Wando Anioku, who is the Chief Health Equity Officer at Swedish Health Services. She's going to be giving our presentation. Welcome.
Thank you. Thank you so much for having me, Robin. Thank you for inviting me to have a conversation with this group. It's rare that I have an opportunity to speak to people whose vision and goals are so very much aligned with mine. I'll take a few minutes just to introduce myself. I am Dr. Wando Anioku. I am a pediatrician by training, have been a pediatrician for a couple decades at this point. I'm going to stop counting pretty soon. And I spent, I did my pediatric training on the East Coast in New Jersey and headed west to the Pacific Northwest about 5 years ago after a brief stop in Omaha, Nebraska. And at Swedish, I led the pediatric enterprise, primary and specialty care, for a few years. And then I was part of the leadership team working on our Medicaid strategy. And last year, in the wake of the George Floyd murder and the social unrest that followed, and the lessons that emerged really quickly from the pandemic, which we'll talk about today, um, our parent larger organization, Providence and Joseph's Health, made a commitment to address health equity over the next few years. And as of 8 months ago, I became the inaugural Chief Health Equity Officer for Swedish Health Services. Really, the common thread running through all of my career path and personal is that of advocacy. As a pediatrician, I wield my craft through advocacy, advocating on behalf of the adorable, as a T-shirt that I loved says. Pediatricians are advocates for the adorable. I advocate for children with their parents, with the adults in their lives who have agency. So that's their parents, the school board, with legislative and regulatory bodies. And, in doing Medicaid work, advocacy is key there. And health equity, as we will talk about today, is really all about advocacy. So next slide, I would like to just share with you what my goals are for today. Really is to raise awareness of what is health equity and to talk about the issues that affect the ability of one population versus another to receive equitable health care, and to have a call to action that really talks about some employable strategies that will allow all of us as advocates to promote the and remove some basic barriers to equitable health care for our patients and our communities. Next slide, I like to ground my work in this thought. Dr. Martin Luther King said that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And that thought grounds me and my team as we embark on this work, and I hope it grounds you too as we go forward with this conversation. In the next slide, I want to talk about some definitions, some concepts, some that are used interchangeably and some that may mean different things to different people. The first one I'd like to talk about, which is often used interchangeably when we talk about health equity, is DEI, diversity, equity, and inclusion. I am privileged in my work to lead the Swedish Office of Health Equity, Diversity, and Inclusion in partnership with my dyad, who is our Chief Diversity, Equity, and Inclusion Officer. Really, that construct allows us to really show what the difference is between the two aspects. And we think about DEI really about having a construct of having a welcoming and culturally inclusive space in which our caregivers, our physicians and providers, and our patients can feel like they can bring their whole selves, right? So the DEI work really talks about our workforce and our workplace and making sure that we have a diverse pipeline, we have diversity in the teams that work, that care for our patients, because we know that there's a lot of studies that show that having a more diverse workforce leads to better outcomes for a diverse patient population. And so that's the work of our DEI. That's the DEI focus of our work. And really, we think about it as a tool necessary to be able to deliver culturally competent, equitable health care. The next slide, I'd like to talk about health equity specifically. And this definition, I always have the graphic next to it to talk about what I'm really trying to communicate. The absence of systemic disparities in health and its determinants between groups of people at different levels of social advantage. Really long description, right? To attain health equity means to close gaps in health outcomes, in health experience between populations who have different levels of wealth, power, and of social prestige. So if you look at that graphic, you see that even to reach the lowest rungs, there's some of us who need a higher box, who need more support. And those boxes tend to represent often social determinants of health, which include nutrition, education, transportation, all the things that we talk about when we talk about social determinants of health. But it also includes some structural inequities that have been built into our system that are a legacy of often of a historic racism in our system. So it shows up in a variety of different ways, some of which worsen those social determinants of health and some of which stand alone by themselves. And that certain category I would give as an example, something that most of the healthcare universe has been talking about recently, and that is the change in how we calculate renal function, just as an example. And there are many other calculations like that. The way that we calculated renal function had race as part of the equation. And what it meant was that because we were calculating that into it, we actually ended up making those diagnoses later for African American patients. And what that resulted in was that they would show up with worse disease and at a later stage of their illness. So some of these structural things have been baked into in fact, all of them have. And so if you think about education, if you think about language access, you see that it starts to show up in multiple different ways. And as we continue our conversation today, I hope I can illustrate it to you even better. The next slide, I'd like to just take a moment to talk about the difference between disparities and inequities. Health disparities are measured health differences between two populations, regardless of the underlying reasons for the difference. So those reasons may be logical, right? So an example that I use is the difference between breast cancer rates between men and women. Well, it's a disparity, but it's a disparity that is explainable, it makes sense, and it's not one that we can do too much about. Health inequities, on the other hand, are differences across population groups that are systemic, that are unnecessary and avoidable, and are therefore considered unfair and unjust. And that's where the social determinants, that's where the structural racism, that's where those issues show up. And that's how they result in inequities in outcomes between different populations. If we look at the next slide, I just have some coins that show, really amplifying the difference in these different groups and how different groups of people require different things to have the best outcomes. I think of when I talk to clinicians, the first thing that clinicians say, nobody comes to work trying to cheat out a different group out of their help. They say to me, I treat everybody the same. And my response is everybody doesn't need to be treated the same because everybody has different needs. And so our goal is to bridge the gap between, and if you go to the next slide, between the ability of our patient to receive our care and the intention of the caregiver. How are we going to make those two things match? So in the next slide, we talk a little bit more. This is a research study that talked about exactly this work. What does it look like to have disparities in different groups? How can we bridge the gap? How do we understand the difference between health disparity and health equity? And so if you're paying attention to these definitions, then you start to see what those differences are and how you can account for them in the care that you provide for your patients. The next slide really tries to summarize what I've just said in one graphic. And you'll see on the right what those boxes tend to be, right? So those boxes that are differential in the ability of patients to receive healthcare represent things like housing, nutrition, education, employment. So if you have a group of people who are disproportionately represented or underrepresented in having those resources, you're going to start to see them show up in their health outcomes being different. And so there's a health system in California that summarizes this definition of health equity in one really simple sentence, and I love it. It says, optimal outcomes regardless of background. That's the goal of health equity. How do we achieve optimal outcomes for all different people, regardless of where they start from? What do we need to do to bridge those gaps? What blocks do we need to put under our patients and wrap our arms around our communities so that they can get the benefit of the healthcare that we are trying to deliver to them, regardless of where they started from? In 2020, about almost 2 years ago now, in Washington State, we were grappling with the first of what hopefully is a once in a lifetime pandemic experience. And the next slide, I want to talk about some of the lessons that we got out of that time. We had the first patient here in Washington and part of our Providence and Joseph's family up in Everett. And we didn't know what in the world was facing us. We were trying to understand what was what this disease was. How did it show up? How was it spread? How could it be treated? All of the healthcare community worldwide was chatting, was calling, was video connecting, and asking, "What are you seeing? How can we do better? What did you do that worked for a patient and what didn't? How do you stop the spread?" And so it was really an extraordinary time. And I'm sure we all share the hope that we are coming to the end of it and that may we never see anything like that again. But it taught us some really critical lessons. If you go to the next slide, very early on, we started to find out that there were some populations that were especially vulnerable. We found out that, as we're watching the news and we're meeting and discussing and reviewing data, we started to see that for African American, Latinx, and also indigenous population, this disease was taking an extraordinary toll. It was hitting these populations more so than the general population. What was it about them? We also found that patients with pre-existing comorbid conditions were being disproportionately impacted by this pandemic. Was it because there were biological reasons why these patients were experiencing this differently? What could we do? How could we even understand what it was that was happening? In the next slide, we started to peel the onion and think about what are the things that are unique to these populations or that differentiate them from the majority. Who is disproportionately affected? Why? Do they have more comorbid conditions? Well, it turns out that these populations also were overrepresented in patients who had chronic illness, who had difficult access to healthcare, who could not safely isolate at home because they often lived in multi-generational households. They could not necessarily work from home because they were overrepresented in the frontline workers, in grocery store workers, healthcare workers, bus drivers, and community-facing jobs. And so for those jobs, you really couldn't work from home. You couldn't take your computer and find a space because you had to be out there. And therefore, it was harder for you to be protected from the public. So all the big organizations sent all their workers home and did what we could to increase social distance among workspaces. But if you were a bus driver or a grocery store worker, you either stopped working or you had to keep going once more into the breach every day. And so we started to see that these were some of the things that were making this pandemic have a differential impact on some of these populations. And then if you got exposed, where could you isolate? Could you get testing? Did you have access to testing? Do you have access to healthcare? All of these things that have been in the background of our health system for many, many years and have been talked about multiple ways came to full technicolor relief in the wake of this pandemic. We could actually see exactly how it started to show up in all these different populations that we were trying to serve. And so in the next slide, we started to think about how these different factors affect the individual health vulnerabilities and what could we do as a population to begin to address it. So as a society, we had to rally, right? And think, okay, there are strategies that we need to put in place because we have to address what is happening with these groups. So testing, who was prioritized in testing? When the vaccine became available, who was prioritized in getting vaccines? How do we get it out to those groups of people? How do we help people to isolate safely? We gave kits. If you couldn't move into a hotel or something like that, then perhaps we could give you a plastic sheet to separate you off from the rest of your family while you're living in a multi-generational household. As you started to look at it and think about it, it was extraordinarily challenging. But it was the silver lining of that cloud was that it forced all of us to look at the impact on all of us, right? So in the next slide, it said that the greatest lesson that came out of this pandemic was that everyone's health affects everyone else's, right? We maybe prior to this time had thought that those of us who had access could sit in our gilded, silk-lined towers and pat ourselves on the back because we had access to healthcare and we made the right decisions and we were healthy and our families were healthy. But now it's not, because we found out that, you know what, if we're going to come out of this thing, we all have to come out of it together. And all our strategies had to be addressed across society. We had to, start to solve for everyone else, because it didn't make sense for you to be safely isolated at home, vaccinated and covered, if everybody you had to encounter when you went out to buy gas or buy groceries or take your children to school was still exposed and we're still suffering the scourge of this illness. And so that to me was the one silver lining of the pandemic, because it forced us to actually reckon as a society about what it was that we needed to do to improve health for the whole society. So the CDC actually wrote a publication, if you look at the next slide, that talked about what were the specific factors affecting health equity as part of their understanding of the pandemic. And the first they called out was discrimination. Examples including healthcare, housing, education, criminal justice, all these different ways, right? Discrimination, which included racism, could lead to chronic and toxic stress. It could shape social and economic factors that put some people, some communities and racial groups at an increased risk for COVID-19. I mean, if you go to the CDC website, they have all of this called out. The second was healthcare access and use. Like I talked about, the group of people who are overrepresented in the population that don't have access to healthcare tend to be those minority populations that were disproportionately impacted with COVID. Cultural differences, lack of trust in the healthcare system because of historical challenges that different communities have experienced, and I won't go into all those examples. We can talk about that at length at a different time. But those things created a problem. Occupation, like I've talked about, education, income and wealth gaps, and housing. A higher percentage of people from racial and ethnic minority groups live in crowded housing. They could not afford to separate, and so their risk of exposure was greater. And in the next slide, what came out of this understanding was a need to build, to bridge this gap. What did we need to do to provide everyone the resources that they needed to have sufficient access to quality healthcare? What did we need to do to give people the ability to social distance, to give access to COVID testing? These things that were, shorthand for more well-heeled or more educated or resourced communities, for some of our communities were a specific challenge. And this pandemic forced us to actually pause and think about how we could solve for these things as a society. Next slide. And so healthcare, which is my industry, had to take a pause, right? Because we were in the line of fire for this thing. And how could we, seeing this data and understanding this impact, what could we do as healthcare organizations? You started, like I said, my role was created just about 8 months ago. And in that time, many organizations have come to the realization that we actually needed somebody to corral the healthcare industry to look specifically at how do we deliver equitable healthcare, right? And how do we call out equity health equity as part of our fundamental tenets of healthcare delivery. Next slide, please. We understood that we needed to practice using an equity lens. We needed to be mindful. We need to take action. And we needed to identify the challenges, right? So that if you were not thinking about it and you thought that what you were doing for everyone was being equally impactful, then you ended up with situations like we were finding ourselves in. So healthcare as a whole rose up to this challenge. In the next slide, the Institute for Healthcare Improvement is an organization that helps us to, if you can go to the next slide, that helps us to think about how we learn this work as a larger healthcare society. So I call this out because anyone who's looking to do this work doesn't need to, build the wheel from scratch. It's been built, it's been tested. There are organizations around the country who are doing this work, and there are learnings that we can share. And so the Institute for Healthcare Improvement put out a white paper that called out 5 pillars for addressing health equity in healthcare organizations. The first was to make health equity a strategic priority. Call it out as part of your mission statement. Call it out as part of your values. And the second was to develop a structure and process to actually support the work. Because it's all very well and good to say that, well, we really want to deliver equitable healthcare, but who's doing the work? You actually had to make that call. And I'm grateful that I had the opportunity in an organization that built that structure and allows me to head it up to address processes to support health equity work. The next pillar was to deploy strategies to address the multiple determinants of health. So those include social determinants, political determinants. They also include, like I mentioned, some of the factors in healthcare that have been built in over the years as a legacy of historical racist policies that we actually have to go after and unravel. And the example of the calculation of renal function is just one. There's a calculation for vaginal birth after C-section. There are a number of calculations that actually have race as part of the equation. And it's not because biologically this group of people is any different from the other. It's because it sort of becomes a self-fulfilling prophecy. You are overrepresented in this group, and therefore you must be at higher risk, and therefore we'll put you into the equation. And basically, you set up a catch-22 because it just keeps self-perpetuating that harm. So that we had to be intentional about deploying strategies to address that. Decreasing institutional racism in the organization is a specific pillar that the Institute for Healthcare Improvement calls out. And that includes thinking about how welcoming is your organization? Do you address racism when you identify it? Is your space welcoming? Do you have art that reflects the population you serve? Does your workforce reflect the population that you serve? How does it look? What makes the door warm and open for somebody who's not of the majority population to feel like they can safely come into this place? How do we show ourselves trustworthy as an organization, not asking for the community to trust us, but taking the onus on ourselves as healthcare to be trustworthy? What is the work that we have to do to accomplish that? And the final pillar is to develop partnerships with community organizations to work on health equity issues. And the most impactful value of that is that we are basically piggybacking on the trust that those community partners have with the community that we're trying to serve. So if we're trying to reach out to a specific group and historically they haven't had access easily, they haven't trusted us easily, who serves them? Who in the community can we work alongside with to get out into that group? So if we're looking at addressing diabetes control in the Latinx population, are there churches that serve this group? Who can we come to and say, you are trusted and we want to come along with you to serve your population. We want to do better by your population. And how can we partner with you in order to accomplish that? Really, really important tenet of delivering health equity. Next slide. I want to call out, okay, this is an eye chart. And the idea is not for you to read it at all. I put it in so that you can sort of think about it over time. But the headings of these 5 pillars are that your goal as a healthcare organization is to understand your community. What are the factors facing this community that you're trying to serve? What are the social determinants? What is the built environment? What are the social, community, political factors that are impacting your patients? It is your responsibility as a healthcare organization to understand that. You need to know the population that you serve. Which patients are using different service lines, right? Who who is able to come through the door. You can't just worry about those who've made it through the door. Who's not able to come through the door? It's important to understand that, to bring that population health lens to the work of delivering equitable health care. Then identify their needs. What do they need most? How do they access you? In the wake of COVID, we went to digital health as a lot of telehealth totally ramped up, and it was fantastic. But you have to know that there are some people who live on the other side of the digital divide, for whom a smartphone or a computer or regular stable internet connection was not really an option. And for those who don't have a teenager or millennial person in their home who can help them sign on and do all the things that have to be done, it's a problem. So you need to be aware of that potential gap as you're developing policies. And then get into the habit of reviewing and understanding your data in a disaggregated form. So filter your outcomes data or even your process metrics by race, ethnicity, and language, or by sexual orientation and gender identity. When you put that filter on the data that you have, I tell people 30 years ago, quality metrics and quality performance assessment was something done by 20 people in a basement somewhere, right? But now every single healthcare institution measures ourselves by our quality metrics. That's the language we speak. That's the way we're assessed. That's the way the community understands what we do well and what we don't do well. But if you report those metrics as a whole, without looking at different populations, you might not identify that you're not serving some subpopulations as well as you're serving the whole. And so a key step in delivering equitable healthcare is disaggregating your data so that you can understand the different groups that you're serving and how the service that you're trying to deliver is impacting them. And finally, you track your progress. So you measure it, you figure out where you are, you put interventions in place, and then you measure how you're doing over time. The next slide is really designed to just show that data is key. You are not going to understand your community if you don't have the data. And sometimes the data exists. Sometimes you have to be intentional about creating it. You have to be intentional, for instance, about putting that filter that I just talked about so that you can identify the patient populations that you're serving and see what their gaps are and start to identify what the drivers are of those gaps. You can review their health outcomes and you can track your progress. But data is the key that helps you to do all of that work. The next slide is a reference article that just talks about the link between health disparity and inequity. Really talking about how you need to understand social determinants of health, the combination of systemic and structural and biomedical factors that create the difference in experience of care for different populations and therefore a difference in outcome. Next slide. So when healthcare started to understand this, the big lesson was they needed to build a bridge. Next slide. And building a bridge looks like, how do you find health advocates, right, to bridge the gap between the healthcare system and the need of the patient? And it was interesting. I give an example that across our larger organization, when we had the opportunity, because we have this commitment from the larger organization to focus on health equity, the single rallying cry from all 10 regions, 7 states, who had now had the opportunity to be intentional about delivering equitable healthcare, was to start to build health advocates into the health system. We immediately understood that was what we needed. We needed to bridge the gap. So the next slide talks about what are the types of health advocates that we could see, right? So we understood that health advocacy is the key to health equity. A health advocate, and I don't need to tell this group that, you know it better than most, that a health advocate can help to address the structural and historical barriers to health equity. They can help to address health literacy. They can be advocates at the legislative and governmental level. They can help with access to health insurance and health payers. And let me tell you, as we are going into the open enrollment season, you would be much loved by everyone if you could explain to the general public how to choose between insurance plans, how to understand in-network and out-of-network, right? So how valuable is it to have somebody who can guide a patient through that? and how to connect them to community partners who can address their social determinants of health, or including homeless services. Next slide. And so a cadre of workers came up in the health system. We call them navigators. We call them community health workers, promotores. We have patient ombudsperson. We have doulas. All of these are healthcare system health advocates. They are what we knew instinctively and through research and experience is what we needed to be able to bridge the gap between what the patients are experiencing and what they need. They also bridge the gap for the patient to understand the challenges of a healthcare system. So, for instance, if you're in a primary care clinic and you have an appointment, but mom has to take the day off, you have to take the day off, you have to take 3 buses, you arrive at the clinic 15 minutes late and you're told you're not going to be seen. Well, you're crushed, right? And the health system needs to understand all that patient had to overcome to be there that day. The patient also needs to understand what the reason why the healthcare system is saying what they do. It helps them, but for the most part, what can they do? If you have to take 3 buses and the bus is late, what can you do? But at least you don't feel like it's a personal attack, right? But as the more powerful entity, the health system, it's important that we are aware of these things and we don't find ourselves in a position where we're punishing and worsening the impact on the patient because we are mad at them for messing up our schedule. So we tell them, you can't be seen today. What that means is that she has to take another day off of work. What that means is that she has to find transportation another day. She has to find childcare another day. You have to be cognizant of those things. And so an advocate can be that bridge and say, let me help you so that if I can get you access to transportation, I can help you get there on time. But healthcare system, let me help you to understand what this person has had to overcome to be here today. And is there a way that we can deliver care to her so that she doesn't have to take another day off work and slay all those dragons that she needed to slay in order to be here today? And so the next slide, I just call out my gratitude to this organization who convenes and shares your expertise and your passion in service of helping patients achieve equitable healthcare, in service of helping the health system to understand what the patient needs and to help support them on their journey. I just wanted to take a moment to say thank you because health advocacy is truly the key to health equity. The next slide has the health advocate standing squarely in that gap, building the bridge between the healthcare system and a healthy, empowered patient. That is what you do, and I cannot thank you enough because that is the work of health equity. The next slide is another eye chart, but I really just wanted to take a few minutes to share with you an example, a 360-degree example of how we did some work around health equity in our health system. And that had to do with the mobile vaccine, with the COVID vaccine when it first came out. As an organization, we started, if you remember when it first came out, there were all these really exciting looking websites where you had to find a link, select and figure out whether you were eligible, and then pick a time and then, confirm, and then your confirmation came across on the text. We looked at that and we're like, okay, this is really cool, but there's a whole subset of people for whom this is not going to work. And so we need to figure out a way to bring the service to those patients right from the start. And we are so thankful that we reached out to our philanthropic partners and we said, this is what we need to do. We need to go out to the community to serve them in a different way, because we know that there are those who are not going to be able to get easy access through this really elegant online process. And this eye chart, which I should take away because it's painful to look at, but I'll just call out, if you have a chance to look at it later, that the second line showed us that the percentage of African Americans in King County was about 6.7%. But the first wave of vaccines that was given out, they had only hit about 3.5%. And so the mobile vaccine effort allowed us to actually start to close that gap. And so the next slide shows the van that we were able to take out. This was our a mobile vaccine clinic in partnership with the Ethiopian Community Center in South Seattle. We we knew that we needed to target organizations that served the Black community because the data has shown us that that was where we had the greatest opportunity. And so we reached out to the YMCA of Greater Seattle and we said, we're trying to find organizations that serve this community because we need to help to close this gap. And they gave us a list because the YMCA connects to everybody. And they gave us, based on our zip code data and the high risk data, they were able to point us to organizations that serve the African American community. And this particular organization was serving a very unique population. They were older, but they had language barriers. They spoke Amharic, and there were a lot of them for whom that online option was just never going to work. And so we approached the community center and we said, this is what we'd like to do. We'd like to bring vaccines out to serve your community. Do you think you'll have people who would be interested in receiving vaccine from us? And they said to us, well, there is a lot of hesitancy, as you can imagine, with receiving this vaccine. It's new and people have a lot of questions. And so we said, well, what can we do? So they came up with the idea, right? Why don't we hold a webinar so that we can invite our community members, our partners into our space, and we'll have you there to answer questions so that they can, in a space that feels safe and secure to them, ask questions about their risks, ask questions about their fears, and have those questions answered by a trusted partner. That for me is the very epitome of nothing for me without me, because they were able to tell us what their community needed. And so we did that. We had a webinar and we were out there, and I think they had about 100 people sign up that first day. And the questions were not complicated. How can I take this vaccine if I'm taking this other medication? Is it safe? Has it been tested sufficiently? Will it harm me? Will it harm my fertility? Will it harm my grandbaby or my granddaughter? How does this show up for me if I take it and the rest of my family doesn't? What are the things that I can do to be better? And it was just a wonderful opportunity to have a conversation and answer the questions in a way that put people's minds at rest. And having answered the question, we had people sign up, and then we showed up with our truck and our tents and our team. And if you look at the screen, the people in the green vest represent the members of the community. So we asked them to bring forward some of their members of their community who could support their community in language, right? So we had a computer-based language translation service, but how much more accessible it was to have people who could support their community members in their language, help them fill out the forms, answer the questions, and guide them through the process. And while we had them there, we could answer other questions that they had. We could give them information about testing and isolation and all the things that we otherwise would not have had an opportunity to do, because those people, for the most part, would never make it through our doors of the hospital because they were not necessarily our patients. And, because they didn't necessarily have access to health insurance and all those things that represent a barrier. So we were able to do this over a period of about 4 months, and so grateful that we were able to close those gaps, right? Not completely, but quite significantly impact the gap between the percentage of people of African American descent. We did the same thing with some Latinx churches. We reached out to the indigenous populations had their vaccines from the Indian Health Service, and so we didn't necessarily partner as much in that space. But as a whole society, we came together to share information. Public Health, King County, and Washington State Department of Health helped with providing information, flyers, data, all sorts of things. And all of us were on the same page because we're all in this thing together. And if we were going to get out of it, we needed to get out of it together. And so I share that as an example of what it can look like when you're intentional about addressing inequities in our health system. You first look at the data and identify who is not being served optimally. And then you try to identify what those drivers of the differences could be. And then you look for who could partner with you in closing those gaps. What are strategies that you can deploy in order to close those gaps? And I'm just incredibly proud of our team for being able to do that work. And once we've built those relationships, we guard them jealously because we know that it will be a channel by which we can address other things. So we're now working on hypertension control. We're working on depression screening. Anything that we measure where we find a gap. Another thing that we're about to launch some work on is diversifying participation in clinical trials, especially for cancer trials. So there's just so much that, there are gaps and differences in the way different populations experience healthcare that, if you put this lens on it and this way of dealing with healthcare, we actually can work towards a more equitable, high quality healthcare system. I'll just take a couple of minutes for us to just evaluate, ask a couple of questions, right? In the next slide, think about, okay, how are we doing with this, right? Let's evaluate. Next slide. What does it look like to you? And if someone misses a doctor's appointment, should they be considered non-compliant because it doesn't matter why they didn't show up? No, right? That's false. If you go next, keep going, because they've had to deal with a lot of challenges, right? And how can health advocates help to address equity? By working with the patients and with the providers to think of other ways to communicate or to access the healthcare system. This is what we're about. This is how we want to do this work. It's actionable, right? All of us are advocates on behalf of ourselves, on behalf of our families and our neighbors. We don't always think about it like that, but in the healthcare system, how much more needed is it? The next slide just talks about another couple of questions, right? So if you think about changing the delivery of healthcare, a simple way to deliver healthcare to everyone is through their smartphone. Is that true? Clearly, it's not. Everybody doesn't have a smartphone, and even some of us who have it can't figure out what one button means versus the other. So we have to be intentional as we develop new healthcare delivery strategies. Today, healthcare is in flux. It is changing rapidly, and we need to have that equity lens on what this new pathway could mean for different populations. I'd like to talk just briefly about the tech world. Technology is a great partner in trying to figure out how to bridge this gap. But technology, if we don't partner with them, today you hear a lot of conversation about artificial intelligence and machine learning. Well, if the machine is learning what the current healthcare system is, it will perpetuate inequity. So we have to, as healthcare organizations and healthcare advocates, come alongside technology as they are deploying their brilliance and their passion and their creativity to ensure that they don't worsen inequity because they're building machines and artificial intelligence that is learning based on a flawed system. So I like to call that out, and I hope that those of you who have an opportunity to partner in that space will do so. Patients who do not have easy access to transportation or childcare can be provided different ways to access vaccines or healthcare through mobile clinics, through mobile mammogram vans, through different ways of delivering healthcare. We all need to be creative because, and the way that we can be creative is being aware of what our patients need, what our communities need. And once we are aware and we engage them as partners, then we can come up with new ways of delivering care to them so that the care that we intend is received in the way that we intend. And I think that is my last slide. I would be happy to take some questions. My call to action is to look at that slide. Just go back to the next one. My call to action is this graphic that is put out by, I think it's Robert Wood Johnson Foundation, the difference between equality and equity. And it really just says that everybody needs to get what they need in order to achieve the care that we want them to achieve. For some, it's a little kid bicycle. Some it's a recumbent bicycle. For some, it's It's a big one, sometimes it's a small one. But ultimately, our goal is to have people moving forward towards a high quality, equitable healthcare system. I will stop now. Thank you for your time, and I will take any questions.
Wow, there's so much to chew on there. We do have a lot of questions in the chat. Thank you for that presentation, and I'm really struck by how much there's a mountain of work to be done in our system in lots and lots of different ways. One of our board members, Sarita Nolan, was asking about especially the disabled community and people from disabled and marginalized communities, such as medical trauma. How does that fit into elevating the health equity equation?
It fits right in, right? Because the principle of elevating the health equity equation is understanding who your communities are, what the diversity in your community is. And the diversity could be based on race and ethnicity, it could be based on language, it could be based on ability, right? So the disabled community, and often there's an intersection between all of those, by the way. So in our mobile vaccine effort, for instance, we actually had one that we partnered with the speech and hearing, the Deaf and Hard of Hearing Center in Seattle, to get vaccines out to the hearing impaired and to the translators for the hearing impaired, because the system just doesn't work easily if you are not, easily fully able in the way that it's designed for. So we have to be intentional about identifying where there are gaps. And we found that there were gaps in the deaf and hard of hearing community, as well as the interpreters for the deaf and hard of hearing community. So we worked with the center that works with them to get vaccines to them. And so, yes, absolutely, thinking about people with disabilities is part of delivering equitable healthcare.
One of the things that I'm really curious about is there's so many gaps, and I loved the so many of your graphics in terms of building those boxes and having the red advocate as the bridge. I thought that was great. How do you grasp the data that shows real improvement? Like, are there metrics across all systems and organizations that can show progress and in what areas?
Yes, absolutely. Like I mentioned years ago, we didn't really talk about quality metrics, but today that is the language of healthcare. So we are required by the third-party payers, by the regulatory bodies, to keep track of certain metrics of performance. So, for example, we have to report out our performance with hypertension control, our performance with cancer screening, diabetes management. So we are required to keep track of those metrics as a health system. And there's a whole potpourri of those metrics, and different payers and organizations focus on different aspects of it. But the point is that there are metrics that we are keeping track of. And my ask is that when you go to those metrics, filter them, disaggregate the data so that you understand those metrics by the populations that you serve. So in Seattle, King County, we know that we have, Caucasian, Asian, African American, Indigenous, we have all these groups of people. Put that filter on your data, right? Do you gather that information in your electronic medical record? Ask it to break it down by those people. And when you break it down, what rises to the top is where the gaps are. So I tell people, I'm not asking you today to create new metrics. You are already measuring what's important to you, how you see yourself as a healthcare delivery system. Go to those metrics, filter them, and see what rises to the top. And when you see what rises to the top, then you start to assess what are the drivers of those differences and what can we put in place to close those gaps. So that's how I would recommend that anyone in the healthcare system begin this work, because otherwise it feels like a lot, right? Oh my goodness, do we boil the ocean? But there's data that you already have. So start with that and start to look at it. And sometimes you hear it come to you from your patients or your communities. They cry out to you for different issues, right? I need behavioral health care. right? In the wake of the pandemic, behavioral health is a full-on separate pandemic on its own. So whether you have data or not, this is an opportunity to shine a spotlight on this area. What can I do to bridge this gap for these patients? So that's what I would say. Start with where you are.
So here's a question from Terry McClellan. Even though we're 2 years in to the pandemic, I'm still seeing healthcare access as a problem. I work primarily with geriatric population, and many have had strokes or MIs and have not gone to the ER out of fear. How do we fix this today now, even though doctors are telling people to stay out of the ER?
Such a profound question. It is so true because, like I said, I hope we never ever live through this again. But in the effort to keep people safe, we kept people out, right? We were like, don't come in, we'll do a virtual visit. Well, you can do a virtual visit to a point. At some point, you probably need to come in to get your cancer screening. At some point, you need to come in so that somebody can measure your different outcomes more effectively. And we are hoping that we're coming to the end of that, right? Because well, in the summer we thought we were raising our head and then Delta hit us back down. But I think, if I just knock wood, that we're hopefully coming to the other side. So as we start to emerge on the other side, we have to be intentional about going back to find those people who have delayed care because access to the healthcare system was limited by the pandemic, right? We have to be intentional about going back to find those people and make it easy for them. What do we need to do to allow those doors to open better? As you know, I was looking at our data last week from, she talked about pediatrics, but about geriatrics, but I'd like to also give an example from pediatrics, right? So those children in the wake of the pandemic, everybody was focused on the grown-ups because they had most of the illness burden.
Right.
But these children are subject to those grown-ups. So if the grown-ups couldn't go to the hospital and they couldn't go to work, well, guess who wasn't also getting taken for their appointments? So now we look at our data about a week ago, and there's this huge yawning gap in Black and Hispanic children in their vaccine rates because they were the children and grandchildren of those populations that were disproportionately impacted. And so because we're looking at it and paying attention to it, we now have to be intentional about finding those children and closing the gaps. And that's what we have to do now as we start to emerge, to think about who has fallen into the gap over the past year or 2 years and find them and help them and bring care to them in a way that's accessible, because it's a very real concern.
Well, and related to that, and in the chat, there's a question from Karen Isaacs about home care being a priority and home doctor visits. And I was interested to hear the mobile clinic that you talked about. And I'm wondering if the future of medicine is more about bringing care into the home where people are.
I think it's exactly that, right? The future of medicine is also and all of the above. Some people need home care, and we are building capacity to be able to develop that. So we have hospital at home, we have remote patient monitoring structures that have emerged and grown rapidly over this past 2 years because somebody might be at home and got a little congestion, a little bit of a cold, maybe they've been exposed. They're not that sick yet, and we don't know if they're going to get that sick, but we have tremendously sick people in the hospital. So do you want to add them into that mix? It would be great if you could monitor them at home and keep track of them to see how their disease progresses, so that if they get worse, you can bring them in because you're tied to them. So delivering care at home is a model that has emerged. Like I said, telehealth is a similar structure, so you can do your visits with your doctor from home, at least a certain number of them. And that reduces your need to get transportation, to take the day off work, to find childcare, because it breaks down a lot of those barriers. But like I said, as we are developing these new strategies, we need to be aware of how they're showing up for different populations. Does everybody have access to be able to get care at home? Do they live in a safe space? Do they feel like they can have their medical conversations in a crowded environment? How does this show up? So as we're deploying and trying out new strategies, we also have to be asking ourselves, how are those new strategies landing for different populations, so that we don't end up worsening inequity in an attempt to close those gaps.
Yeah, absolutely. And related to that, and people across the nation probably are familiar with the people who are experiencing homelessness here in the Seattle area. It's a huge, huge issue for many of our neighbors. And so, question from Melina Houston is, has Swedish taken any steps to address access issues for the homeless population in King County, which is our downtown Seattle area?
Yeah, we are certainly doing what we can to get healthcare out to improve access to as many populations as we can. And we have our mobile vaccine unit, for instance, goes out to homeless encampments to give vaccines to homeless people, because there's not really an easy access to healthcare for them. And so how are we partnering with organizations that provide housing for the unhoused to help them to get access to that, and to deliver care in those spaces? We are trying incrementally to work with organizations who work with the homeless to bridge those gaps. And those gaps may be behavioral health care. It may be, providing, virtual visits in spaces to people who would not otherwise be able to receive it. So we are partnering with community-based organizations who serve the homeless so that we can improve access to care for the homeless. And I think we also have, as part of our community health investment, we're investing in a partnership to provide housing for the homeless in the greater Seattle area. We are a fraction of the solution, but we are trying to be a part of the solution.
Wow, that's amazing that you're investing in housing. And I was also struck by the enormity of all the support that needs to happen in order for people to have what you said, optimal outcomes regardless of background. I thought that was a great quote from your talk. Are there other investments that our hospital systems and healthcare systems will have to be making in order to achieve that goal?
How long do we have? Yes, there are definitely other investments that we can make. And the mindset is to think about, what are the channels that exist and what are the ones that we need to create? So as healthcare organizations, one of the things we're tasked to do is community health investment and community health benefit. And what that allows us to do is to identify what are the risks and the challenges that our community is facing. And we do that every 3 years through a community health needs assessment. And the community tells you, this is what we need. We just completed one in Swedish, and we should have the report out in a couple of months, but actually in just about a month. But the community says to us, we need help with behavioral health. We need help addressing racism. We need help with obesity, diabetes. They tell you what they need. And then you use your community health investment dollars to put strategies in place to address those problems. And the way we do it is to partner with community-based organizations who are serving those needs. Because the challenge when you start to think about this is that you feel as an organization or as an individual, how much can I really do? You can do a lot in partnership. And so partnership is a really key part of how we start to solve these problems. It's a concept of the medical village, so that everybody in the community is working towards the goal of improving the health and equitable outcomes for the people that we serve. You can't do it alone, at least not efficiently and not quickly, but you can do it in partnership. And so being intentional about building those relationships and partners is the way I think that we can move this work ahead quickly.
Well, Dr. Anioku, thank you so much for spending an hour of time, and it was very fascinating, and more to come as HealthAdvocateX explores more of our own DEI initiatives. We're excited to continue to engage with people like you to help bring this to the advocate community. So thank you so much.
Thank you for having me.
And we'll be back. We'll take a short lunch break for an hour and 15 minutes. And our next session will be session 6, The Changing Tides of Primary Care, Grace, Advocacy, and Resiliency During COVID. We'll hear from doctors Jane Dunham, and Norris Como. So see you in a little bit.